Good afternoon. My name is Veronica Judy Cecil, Senior Deputy Commissioner for the Kentucky Medicaid Program, and we welcome you to our monthly meeting where we have the opportunity to provide updates about what's going on in Kentucky Medicaid. Just for those of you who have been with us since April of 2023, we were providing this opportunity to provide updates on the public health emergency unwinding, but now have shifted into providing both information on renewals, continued information on renewals, but we wanted to expand it now to other things happening in Medicaid as an opportunity for us to share that information. So thanks for joining, and we will get started. Let me say, if you have questions, if you could put them in the chat, we will follow and do our best to pull those questions down and answer them. But certainly, if we don't get to something, then we'll follow up afterwards. And so today on our agenda, we have several updates, and we're providing some information about events that we are having and have held, as well as the waiver slots. We're going to talk about some service expansion updates, both community health workers and expansion in hearing, dental, and vision services to adults. We'll give our update on Medicaid renewals and eligibility. We've got an update on our reentry efforts, and lots of great information there. We're using this. We know we have a lot of providers that join us monthly, and so we wanted to use this opportunity to discuss how to navigate appeals and complaints. And then our program spotlight this month is on our behavioral health initiatives. So we could go to the next slide.
I'm sorry, I was not able to unmute myself. I apologize. So the first thing we wanted to talk about was just to share an update about some ongoing in-person provider forums that we've been hosting across the state. They started in September. And again, these are forums really targeted toward the Medicaid provider community, and that is all Medicaid providers, physicians, pharmacists, dentists, behavioral health providers, all Medicaid providers. And it gives us a chance to get out across the state and connect with providers, share important information about Medicaid, allow them to meet some of our sister agencies and have them talk about how they work with Medicaid. We also have been hosting division meet and greets, so providers have a chance to actually meet some of the representatives from DMS. And a big shout out to our MCO partners who have had their provider representatives present at all of these forums to meet the providers and also answer any questions that they might have. So far, we've traveled to Bowling Green, Owensboro, Louisville, and Covington. So if you weren't able to attend those events, good news, we actually have a few more coming up in October. So if you take your phone out and you scan that QR code on this slide, it will actually take you to a page on our website where you can access the registration links. And we're going to be in Covington on October 9th, in Moorhead on October 23rd, and then we're going to be in Pineville at Pine Mountain State Resort Park on October 28th. So definitely register for those if you're a provider and you're interested. They're really great events. We serve snacks and free lunch. There is no charge to attend the forums. So if you're interested, please think about registering because we would really love to have you there. And next, we're going to talk about Recovery Month and an event that we actually get to participate every year. And we just wanted to share an update about that. So we have this event at the Capitol every year. This year, we were on the South Lawn. The event was outdoors. As you can see, Governor Beshear was there as kind of our keynote speaker, and some other representatives from the Cabinet for Health and Family Services were there, including Commissioner Lee, and our Cabinet Secretary, Eric Friedlander, spoke along with some of our sister agencies from the Office of Drug Control Policy and the Department for Behavioral Health. It's a great event. Again, it's in honor of National Recovery Month, and it's just a day of celebration where people who are in long-term recovery, as well as people who are working in those treatment and recovery spaces, get to come together and really celebrate recovery and focus on stories of hope and resilience. That is really the best part of the event. We actually hear from people who are in recovery who share their personal stories, and it's just really inspiring. It's a great way to celebrate and come together and do a little networking. This year we had 89 partner agencies present at the event, which was just incredible. We had information tables spread out across the South Lawn. We also had our mobile harm reduction unit there. They passed out Narcan and did HIV and Hep C testing. So it's just a tremendous event. Some of you may have been there. If you were, we thank you. We're so appreciative for that support. And if you didn't have a chance to attend, and as this is something you are interested in, please save the date for September 15th, 2025. 10:30 a.m. to 2 p.m. We're going to be back on the South Lawn because we really love that location, and it turned out to be such a great event. So please mark that on your calendars, and we hope that you will join us next year. And with that, I'll hand it over to Leslie Hoffman.
Next slide. So I'm going to go over the waiver slot update, and this is waiver slots regarding the 1915C home and community-based waivers. If you're not aware, I'll just go over that we have 6 1915C waivers here in the state of Kentucky. And we were able to obtain additional what we call slots, opportunities, or allocations here in Kentucky for 4 of those, which you will see on the slide here. These waivers that we have are alternatives to nursing home facility of placement and or our intercare and intermediate facilities here in Kentucky. We have to maintain budget neutrality for these waivers to understand that these folks would receive in the community the same level of care as if they were in an institutional type of setting. So we were very lucky in the budget to obtain these slots. So for the Michelle P. waiver, as you can see there, we received, that's fiscal year 25 and 26. We received 750 slots. We're currently in 25 have 250 of those. For the acquired brain injury long-term care waiver, we have 50 total. 25 were in the 20 fiscal year 25. Home and community-based services, we received 750, and 250 of those were in fiscal year 25. And the supports for community living waiver, we received a total of 375, with 125 being in the fiscal year. Do want to remind everybody on the call, even if the budget approves, we still have, even though the budget was approved, we still have to ask CMS for the ability to add those to our current application and to be able to release those slots. So just wanted to let you know that that's where we are. 25 has already been released, and we are working on the upcoming fiscal year 26. So again, CMS has to approve, but this is very exciting that we did or were able to receive these slots. We currently have about 35,000 people accessing the home and community-based waiver services. The umbrella is called, let me just go over that, Beth, real quick. The umbrella for all of these is called the HCBS waiver, not to be confused with the oldest one, which was the home and community-based waiver. So we started out with the oldest one being named for the umbrella or the opportunity at CMS. That's it. Thank you.
All right, thank you, Leslie. So now we're going to shift and just provide an update of some new coverage that came out over the past year or two, and we wanted to provide an update on what's happening in those areas. The first is community health workers. We did start covering community health workers July 1st of 2023. A community health worker is someone that can be hired by a provider, and there are certain provider types that are allowed to bill for community health workers, but they can provide help. Community health workers can help provide a lot of support to a Medicaid member or that provider's patient, helping them navigate if there's education that's required. They can help navigate that. Knowing how to provide the service, if they have questions about the service. So we aren't seeing as much of an uptick in this as we had hoped, which is one of the reasons why we're trying to highlight it, is to encourage more providers to utilize community health workers. We think they're a wonderful support to the Medicaid member. So since July 1st of 23, we've had 39 providers bill for it. The approximate reimbursement for that is around $35,000, and they have served 1,218 members. We will post a link to the site on our Medicaid website that talks about community health workers if you want to learn more about it, if you're a provider who is interested in maybe bringing on a community health worker. There are certification requirements, and that is done through the Office of Community Health Workers. So the CHW has to be certified, but the billing instructions and all that is on the website. So we'll definitely share that with you all in case you're interested. And there's, if you have questions about how to get that started, certainly reach out. We'd like to encourage more providers to utilize the service. Next slide, please. We also wanted to give an update. We expanded dental, vision, and hearing services to adults. We typically covered these services for children, and if a child aged out into an adult and still remained in Medicaid, they no longer got coverage for a lot of the services. So we were happy to expand that. Since that expansion, we have covered 7,150 dentures, over 2,500 crowns. I think really the big thing that we see coming out of this is the over 113,000 pairs of glasses. What we know and through our research is that if you can't see and you can't hear, you're probably going to have trouble even navigating your health care coverage. So we're happy to be able to provide these services to adults now, and we're going to continue to monitor that expansion and report out on the utilization of the services because we think this is making a difference. Next slide, please. Okay, we can move forward. Next slide. So as I mentioned at the beginning of the meeting, we had been typically focusing these meetings on the public health emergency unwinding. And in case you've forgotten, we were for 3 years under a public health emergency. We had stopped all renewals. We continuously, what we call continuous enrollment for members during that period of time. We were not permitted to terminate them. And then the public health emergency ended, and we had to restart annual renewals for members. Not every member goes through a renewal, but the majority of them do. And so at the beginning of what we called the public health emergency unwinding, that's the restart of renewals and sort of unwinding out of all the things that were put into place for the PHE. We started our renewals in May of 2023. We went through a 14-month process of those renewals. We allocated the renewals across that unwinding period, and we did that for various reasons. Primarily, though, is to help with our workforce, not to overwhelm our workforce. So we did wrap those up. We had a few cases in June of 2024, but we did wrap up the majority of that through May of 2024. These are folks, just as a reminder, that were on our, were covered by Medicaid, and come that April 2023 date, we then had to restart renewals. So we had about 1.1 million folks that we had to restart renewals for. We are coming out of some of the, as part of that first cohort of renewals, we're kind of coming Out of those, we've had several flexibilities in place. You may remember that we have been extending members if they had an active renewal and we sent them a notice and they didn't respond. We've been extending them for 1 month. And then if they were a long-term care or 1915C member, we were able to extend them up to 3 months. That flexibility continues, and as do a lot of the other flexibilities we've put in place for eligibility enrollment. Those flexibilities are extended through June of 2025. One other flexibility that we really have been focused on is what we call the 90-day reinstatement period. So if a member following their renewal month and they're terminated, if they come back to us within 90 days and provide the information and we can determine them eligible, we are able to automatically reinstate them if it's in that 90-day period. So they'll get reinstated back to their termination date and there'll be no gap in coverage for that period of time. We've been doing a lot of reporting throughout this period and ongoing. So by the 8th of the month following the renewal month, we have to file a report with CMS to let them know how many, basically the processing of the renewals, how many approved, how many terminated, how many pending. And then there is also what we call the updated CMS monthly report. And that is an updated report we file with CMS that follows after the 90 days following a renewal period. And in that updated report, all we're reporting on is any pending cases. That's the only change that happens in an updated report. So if on the renewal month, original renewal month, an original CMS monthly report, we said 2 people were pending, on the updated report we file after the 90-day period, we would tell CMS how many of those pending were actually processed. We can go next slide, please. This is the trend of enrollment. So we were really at our largest during the, while we were waiting during the 3-year public health emergency. We actually almost hit 1.8 million people covered by Medicaid. And as we came through unwinding, we knew that we had folks that were no longer eligible. Our system, even though we were not allowed to terminate people, our system was still going in the background and kind of doing that redetermination. And so we knew there were some folks that were likely no longer eligible once we had to start renewal. So this wasn't completely unexpected. We've been monitoring it very closely. We, when we see spikes or trends, we've been checking those out just to make sure that people aren't falling off unnecessarily. The majority of folks who have been terminated have been the reason has been for procedural reasons, and that is they did not respond to that notice. So we've been doing a lot of outreach during this period of time to make sure that folks have they know they're going through renewal. We send a written notice, but we also call, we text, we email. We've been doing a lot of things to try to reach members where they are. And we've been asking providers and advocates to help us if they are interacting with a member to make sure they know that renewals have restarted and that they might have to take action. So we are, doing all we can to make sure those folks are aware and are able to navigate that renewal process. Next slide, please. So I'm not going to go through this entire slide, and these slides will be provided. But what we've been trying to show folks and have kept the kind of this running is on the left is that original CMS monthly report I discussed. So after the month is finished, we then report by the 8th of the next month to CMS. That's what you're seeing on the left-hand side there. That middle bucket is that 90-day processing of pending cases. So as you can see, let's take, for example, May. We reported 94,705 individuals were subject to renewal. We had 51,534 approvals. we had 37,464 terminations. And at the end of the month, when the month ended, we had 816 folks pending. And by pending, I mean they have responded, but the state has not processed that information. So then the updated report is on the right-hand side for each month. So for example, in May, we did process all 816 of the pending cases. And then you'll see where they were, oops, I see a typo in the approval. It was not 519,000, sorry about that. It was actually, I think 51,938. And so they get put in the right bucket, whether they were approved or terminated. Next slide, please. And then for this, we just kind of focus on the past 3 months. The reason for that is because we like to show where we are tracking that 90-day reinstatement period. So looking at the most recent month, which is August, we don't have September yet because it's not at the end of September. So our September renewals have not finalized. But looking at August, we had 36,136 individuals going through renewal. We had 31,823 approved. That's a very high number, even though the numbers are low, that's a high percentage that we were able to approve. When we had 979 terminations, we had 2 pending at the end of August. And then the extended column there you see that shows 3,332. Those are the folks I mentioned that we have that flexibility to extend them 1 month or up to 3 months if they're long-term care and 1915C waiver members. On that far right is that reinstatement number that we're tracking. So as of September 13th, we already have had 163 folks come back in following their termination in August. So tracking that number to make sure, we can see when folks are coming back in. Next slide, please. We like to provide this information for everyone, regardless of where you are, if you're an advocate, if you're a member, if you're a provider, just knowing that there are various ways to get assistance, and they are in every county. So there are connectors, there are licensed insurance agents that can help members both with Medicaid and a qualified health plan on Connect. So if the member is no longer eligible for Medicaid and has been determined ineligible, they can also help them navigate how to go out and choose a health plan on the marketplace. For those 65 and older, you could definitely call the SHIP line. That's the State Health Insurance Program. And they will help people navigate Medicare, enrollment in Medicare, because you are required once you reach that age to apply for Medicare. And then this is our unwinding website where all this information is. It also has all the monthly reports I just went over, both the original and the updated. We are continuing to post those on that website. Next slide, please. For those providers out there on Connect, we did, prior to starting renewals, we did alter our page on when you go into KY HealthNet, not Connect, KY HealthNet, that the redetermination date has been added to that. And that is because providers, as members come in for service, and you're checking for their eligibility, and you see that, and maybe it's the month, same month that they're visiting you, or maybe it's the next month. You see that date's maybe the next month, and asking them if they have received a notice, have they responded to a notice, and if they're not sure, sharing the Connect number with them, they can call and check on the status, and maybe we've got an outstanding request that they need to respond to, so we could process their renewal. Next slide, please. And also, this is for everyone out on our unwinding website. We have lots of educational information and informational bulletins. So if you're welcome to pull these down, you can post them, you can share them. It really is helpful information about navigating renewals, what happens if you were terminated, Are you trying to create an account on Connect for your self-service portal and having trouble? There's a lot of helpful information in there. And we just ask that, you share it if you're in a position to help a member navigate their renewal. Next slide, please. And this is the website, just showing you, we've got all of our, the monthly meeting information is on there. All the reports, we have frequently asked questions, all of the communication materials I just discussed, all that information's out there. Next slide, please. All right, I shall turn it over to Angela Sparrow. Thank you.
Thank you. Next slide, please. Again, Angela Sparrow, I'm one of the behavioral health supervisors within the Department for Medicaid Services. And again, want to provide a few updates and ensure that we're transparent regarding the Reentry 1115 project and timeline that we have discussed over the past few months in the monthly meetings and forums. So again, you can see here in terms of where we currently are in this quarter, we have completed community partner engagement activities earlier this month. And again, this was to support the mapping of the current state of reentry services, and then again, to identify the needs and gaps. So this included focus groups, interviews, data requests, working sessions with individuals with lived experience. Our behavioral health providers, MAT providers, so medication assisted treatment providers, primary care providers, state agencies such as Department for Public Health, Department for Aging and Independent Living, Department for Community-Based Services, again, our managed care organizations. So again, an array of stakeholders to gather information again to really complete that comprehensive needs assessment. And so we are wrapping up the review of the completed gap analysis in our current state assessment. And this will drive, again, kind of our next steps towards identifying what our action steps are for our reentry implementation plan. And again, we can see here that our implementation plan is due to CMS by the end of October. And so again, just to note that this will be still somewhat high level, but we will continue to work regarding, again, some more of those finer details at the implementation while CMS is reviewing the plan. We'll also, again, continue to meet with our ACRES Advisory Committee, which we did meet a couple of weeks ago. And up until now, again, has been a little more informational sharing. With that group, we did provide some of the preliminary gap analysis findings. But again, in the months to come, will be more of those decision-making meetings. And then again, also continuing to meet. We do meet weekly with our work groups, our Department for Corrections, Department for Juvenile Justice, again, to really walk through some of those process and mapping. Following our implementation plan submission, we can see here that the state does have monitoring protocols. And so this, again, is we're outlining to the Center for Medicare and Medicaid Services, CMS, how we'll monitor progress and outcomes under the demonstration in the project. And this is due to CMS the end of November. And then we also have some additional deliverables that are due the end of December, and that includes the evaluation design. And so the evaluation design is actually completed and drafted by an independent evaluator. And so they're going to be reporting to CMS in terms of the program and evaluating that for Kentucky, and then again for CMS. And so that is due the end of the year, as well as the state's reinvestment plan. And so then we can see that the go live for the reentry project and implementation may not actually occur until later in 2025. And so CMS does have to approve the implementation plan before we can begin to implement. And this time frame is unknown, but we are hopeful that given the approval package that we can have a timelier approval for the implementation plan so we can get started. And so following that implementation plan, there are several activities again that occurs. And so the state can then begin to implement those necessary changes. This can include state plan changes. It can include regulation changes, system changes. And so specifically for the reentry demonstration, we are looking at again, we can expect that there will be changes to the health data exchange platforms, our MMIS systems, establishing new provider types for DOC and DJJ that will be providing services under the benefit package. And so again, that's enrolling them as new providers, billing systems, credentialing. And so again, we can see that a lot of those efforts will occur during that time period. And then again, also for hiring new staff, training new staff if needed, but then also educating and collaborating with our community partners, and then again with our stakeholders regarding the implementation to ensure that we are ready to implement within that time period. Next slide, please. And so along with reentry with the reentry demonstration, there's also, as a part of the Consolidations Appropriations Act, so CAA of 2023, Congress did include, there's a section noted as 5121, and this does address Medicaid and CHIP requirements for beneficiaries that are incarcerated or for youth that are placed in detention settings. And so do want to note that section 5121 is mandatory and will be a state plan covered service for the eligible juveniles. And so for the purpose of this mandatory act in section, they do define an eligible juvenile as a Medicaid eligible individual who is under the age of 21, but it can also be an individual between the ages of 18 and 26 who's eligible for Medicaid under that mandatory former foster care children group. And so based on the definition of the eligible juvenile, this does include an array of settings in which the individual can be placed. So it can be in state prisons. An eligible juvenile could be in a youth detention center, a youth development center, or again, our local jails. And so under the section 5121, state Medicaid and CHIP programs are required to have a plan in place and to cover, so this is going to be within 30 days of pre-release, certain screening and diagnostic services. And that's under the early and periodic screening and diagnostic and treatment benefits, so EPSDT. And then again, this will also include, so this does include behavioral health, and then even dental screenings and diagnostic services for those eligible juveniles that would be covered under this section. And so again, those eligible juveniles would have received a disposition in our, again, post-adjudication. And so the individuals, again, eligible juveniles will also be eligible for targeted case management services 30 days pre-release, and then again 30 days post-release. And so states have been notified that the provisions are to take effect January 1st of 2025. And so CMS, Center for Medicare and Medicaid Services, did just recently release guidance on the terms and state requirements. And so we have been meeting with the correctional partners to review the provisions, under the act. And then again, are working to include CAA planning parallel to our reentry demonstration. And so we'll be engaging with organizations such as Kentucky Jailers Associations and our Judges Associations to discuss CAA provisions, especially in our jails, and how to plan for implementation in the next few months. And again, states will be having one-on-one calls with CMS in October to address those outstanding questions that we have around implementation of CAA and the provisions. But again, also what states are really looking at is how we're defining effective date of 1/1/25 versus, again, what does an implementation look like for states as of 1/1/25. So hopefully, again, in the next month forum or thereafter, we'll have some additional guidance from CMS to share with you all. Next slide, please.
All right, good afternoon, and my name is Jeremy Armstrong DeRosset, and I am the Assistant Director for the Division of Health Plan Oversight. And so I'm going to be talking through some provider appeals and complaints process. Next slide. So for appeals, there's two paths to appeal. One, a member can file an appeal on their own behalf, or a provider can actually act on the behalf of the member for the appeal. But the member does have that first level MCO member appeal to submit directly to that MCO partner. When that decision is received, as far as the render decision from the MCO, if the member still does not agree, there is a second level of appeal for that member, which is called the state fair hearing process. As a provider has the process to follow for appeals directly for that first level appeal within their managed care entity. Beyond that first level appeal is also a secondary appeal level, which we call the external independent third-party review process, which is an external awarded contracted vendor of the state that will review and render the decision that was made by that MCO at that first level appeal. And then beyond that external independent third-party review for a provider, the provider can then ask for an administrative hearing. Next slide, please. We're going to take a moment and speak more at the member level for appeals. So again, you heard me state that providers may appeal on the behalf of the member, but that is still considered a member appeal. The member must also provide a written consent for that provider to represent them in that appeal level. The appeal must be received by the MCO within 60 days from the date of that adverse determination notice. Non-expedited appeals for the member must be rendered a decision by that MCO partner within 30 days. The member can request an expeditious appeal request in which that MCO partner is expected to render a decision within 3 business days. There is also a continuation of services that is allowed. So if the service is denied in whole or in part, that member will have 120 days to request that state fair hearing. Next slide, please. So this next slide is more driven around the provider appeal process. The time frame for the provider to request is truly determined by that MCO's provider internal appeal process. There is only one provider internal appeal, and it applies to prior authorizations, service denials, or claim denials in whole or in part. When the appeal is submitted directly to the MCO partner, the MCO partner again must make an internal appeal decision within 30 days. There is an opportunity for a provider to also request a peer-to-peer review. The peer-to-peer reviews are not required, but may occur separately from the internal appeal process, and this does not affect that 30-day decision requirement. MCO partners may need additional time to review that first level appeal request. So MCOs may request directly to the provider a 14-day extension, but they must request that directly to the provider for that additional 14 days. As the provider, you should always include all the necessary documentation to support the appeal in which you find the MCO to be erroneous in their decision. Upon receipt of the final internal appeal decision, as the provider, you have 60 days to request that external independent third-party review. And again, that is an external entity of the state that is only reviewing how that MCO's decision was made at that first level appeal. Next slide, please. So the external independent third-party review process. So this is an appeal process that is appealing the decision at that MCO's internal first level appeal. The provider has 60 days from the appeal decision to send an external independent third-party review request directly to that managed care partner. The MCO must notify DMS, provider, and or member within 5 business days. So you'll receive an acknowledgement letter. The MCO will then have 15 business days total to upload their supporting documentation for us to review and to determine if that case is eligible for the external vendor to review and render a decision. DMS will also notify the MCO and the provider of that external reviewer entity, which we contracted as a state, IPRO, which is up the acronym at the top, and that just stands for the Island Peer Review Organization. Our Island Peer Review Organization has 30 days to review and issue a final decision. The MCO member, within 10 business days of receiving that final decision, you will receive that notification. The MCO or provider has then 30 days beyond that external independent third-party review decision to request an administrative hearing. Next slide, please. So wanted to give the opportunity to share some of the denial reasons in which the department deems an external independent third-party review request invalid. And I'm not going to go through all 8 of these, but mainly hitting the points of that we see the most denial reasons that we do have. For number 3, which is did not identify each specific issue and dispute. So as a member or provider, if you're not clearly stating the basis and reasoning in which you are requesting the first level appeal or even the external independent third-party review request, we may deem that deficient and deem that external request invalid. Also, we may deem this case invalid for any rate or contract disputes, as rate and contract disputes are not eligible for external independent third-party review. And that is because we afford our managed care partners within their MCO contract flexibilities to negotiate the rates and payment methodologies in which the providers receive. Next slide, please. Okay, so for the administrative hearing portion, so this must be requested within 30 calendar days of the external independent third-party review decision. It can be requested by either the MCO or provider, but most importantly, I want to identify that the party that receives that adverse final order will be responsible for that payment of a fee of $600 to the department within 30 days. Below that, you will see where the avenue of submission for a provider or member to submit their administrative hearing request. Next slide, please. So now I'm going to change it up here just a little bit and talk about the managed care organization dispute form. So I talked about appeal levels and a lot of timeframes in which providers and members are expected to meet, but that's not your only support. We have a MCO dispute form published to our DMS website. You can actually follow that link there that's here on the showing on the screen, or you can go out to the DMS website and search MCO dispute form. You will actually be brought to this link in this landing page where you'll have a 2-pager of information to read through. The first page is just really an emphasis to ensure that providers are following all the first level appeal rights by engaging with that MCO partner to allow that MCO partner the opportunity to address that issue or complaint in a timely manner, whether that's an identified policy or identified claim system issue. It will afford that MCO partner to facilitate a resolution for you. However, we know and hear that MCO partners are not always resolving these issues in a timely manner. So this managed care organization dispute form is your support to be able to come to the department to file a issue or concern that you're having, whether it is my MCO provider rep is not communicating, I'm having credentialing delays or contracting loading delays. There's an array of things that we contractually require the MCOs to follow, and that's nothing that is super secret. We also have a publication out on our DMS website for all managed care contracts. But more so, the importance of the managed care organization dispute form is to know as a provider and as a member that there is support here at the department level in which you can come to us by filling this form out, supplying us with your supported documentation, your call reference numbers, your email communications, any correspondence that is tied back to this issue or concern is definitely something that the department would want to see and would expect to see included when submitting these types of disputes to the department. Next slide, please. So again, just some key takeaways when it's involving a provider complaint or a provider dispute against that managed care partner. Always, always contact your MCO provider representative first. Each managed care partner has a requirement per the contract that has an established MCO provider representative in your area, in your region. So if you are not aware of who your MCO provider representative is, please know you can come to the department directly to me to obtain that information, but more so you should be engaging with your managed care entities to identify who your managed care provider representative is for your region. Also, for your provider complaint, please be sure to ensure that you include all that documentation that applies to that complaint. That's including, again, those email correspondences, the claim information, really a brief description of the issue, and any supporting documentation that you have. Always, always identify the MCO. Don't want to receive a dispute that just says broadly, here's an issue. We need to know specifically if this is something being driven by one MCO partner or across the board with all 6. And then if the provider has gone through the MCO internal appeal process and wants to file a complaint, include that information as well. We want to see how that MCO partner rendered that decision. And we also want to make sure that you are following all those first level appeal rights that are afforded to you as the provider and member. Next slide, please. Thank you.
Next slide, please. Thank you. So again, Kentucky Medicaid, and we do want to provide some information and some updates again regarding the behavioral health services and initiatives within Medicaid. So again, Kentucky Medicaid did expand in 2014 as a part of the Affordable Care Act to include coverage for behavioral health services. And so again, behavioral health services do include mental health and substance use disorder, substance use disorders, so SUD. And again, we're currently covering a continuum of behavioral health services, and this can range from inpatient services as well as SUD residential treatment services to all levels of outpatient services. And then again, supportive services, which you may be familiar with as peer supports or targeted case management services. So in addition to the covered services, Medicaid also has several behavioral health initiatives where, again, to demonstrate and pilot innovative approaches to delivering as well expanding behavioral health services. And so the behavioral health policy team within Medicaid provides policy guidance for the behavioral health services within DMS, and again, oversees some of the programs that we'll review today. Next slide, please. And so again, want to start with Team Kentucky, the 1115, Section 1115, and the components under Team Kentucky. So the Section 1115 demonstrations, again, these are pilots or demonstration projects that promote objectives of the Medicaid program. And this really gives states opportunities to design and improve our programs. And 1115 projects focus on evidence-based interventions that drive quality and better health outcomes. And so, again, Kentucky's Section 1115 demonstration entitled Team Kentucky, it was initially approved in 2018. And so there, again, we can see here, since then it has grown and continues to grow. And so there are several components and projects under Team Kentucky. I want to talk to you a little bit about that in the umbrella of Team Kentucky. So to start with, we have Kentucky's reentry Section 1115. And again, this was recently approved in July of this year. And so the reentry 1115 allows Medicaid coverage for certain services to our justice-involved individuals in state prisons and our youth development centers. And again, this is really to ensure that we have continuity of healthcare coverage, both pre and post-release for the individuals that are returning to our communities, and to address, again, those medical, behavioral health, and those health-related social needs. So housing, transportation, food, employment upon release. And then we also have Kentucky's SUD Section 1115 demonstration, and this was approved in 2018. So it's one of those initial approvals, and it was implemented in 2019. And so the extension of the demonstration is pending with the Center for Medicare and Medicaid Services, CMS, And we are hopeful that we'll have this approved and the extension approved by the end of this year. So the SUD 1115 essentially allows reimbursement up to a statewide average. It defines that as a statewide average length of stay of 30 days for our SUD residential treatment services. And we also, again, have a waive of the institution for mental disease, so IMD exclusion, and this allows reimbursement for up to 96 beds for residential treatment for programs that are meeting qualifications and standards required under the demonstration. Whereas prior to this, again, we could only reimburse up to 16 beds. And then we also, again, have with the initial 2018 approval, Kentucky was approved, and we did extend Medicaid eligibility to the former foster care youth who are age, again, 18 to 26, and that were in foster care under the responsibility of another state. And so this too extension is pending with CMS, and again, hopeful to obtain that approval by the end of this year as well. And we also, as a companion to the 1915I state plan amendment request that we, again, many of you have probably heard about, we did request in May of 2023, we submitted an amendment to Team Kentucky to request a serious mental illness or SMI section 1115 demonstration. Again, very similar to the SUD. This would allow reimbursement to a statewide average length of stay of 30 days for inpatient treatment for adults with serious mental illness. And we, again, are hopeful that we'll get that pending approval with the extension request at the end of the year as well. And along with that May 2023 amendment request, we also included a request to pilot a recuperative care service. And so this also is known as medical respite. And so Kentucky did request authority to reimburse for recuperative care services as a part of the Medicaid benefit. And this would be for adult beneficiaries who are homeless or at risk of homelessness. And again, they may require additional medical support and care coordination following a hospital stay. Or again, it could be for a planned procedure. So to ensure, again, that they have the necessary support to even be able to obtain those, again, planned procedures. And then we do have one last, again, pending component under Team Kentucky, and again, likely will fall under our SUD 1115 extension approval. But this, again, is around the Recovery Resident Support Service, so RRSS. And DMS requested authority to reimburse. It would be for up to 90 days for a recovery support service. And this would be for eligible adults with SUD transitioning to the community under the reentry demonstration, and then also for those individuals participating in the Kentucky Behavioral Health Conditional Dismissal Program. And again, we do want to note that Kentucky is not requesting reimbursement for recovery housing, but the request, again, is for us to be able to develop a service which may be provided by recovery residents, and again, that meet those standards, those established standards under the service and criteria for the service. And so again, we are hopeful to receive this approval along with the extension request and those other pending components. Next slide, please. And so next, again, we have the Certified Community Behavioral Health Clinics, or CCBHC. So in 2020, Kentucky was selected to participate in the CCBHC demonstration. And so the purpose of the CCBHC project is to increase access to and then improve the quality of community mental health and substance use disorder treatment services across Kentucky. And so CCBHC, it does provide person and is to provide family-centered integrated services, again, for individuals with severe mental illness, for substance use disorders, for children and adolescents with serious emotional disturbance, and then again, those individuals with chronic and complex health conditions. And so this is a 2-year demonstration. It was implemented January 1st of 2020. 2. And so I should say it was an initial 2-year demonstration, but it has been extended through December 31st of 2027. And so there are currently 4 community mental health centers or CMHCs that participate in the project, and that's 7 counties: North Key, New Vista, and Pathways. And DMS again does continue to evaluate the progress of the demonstration and options on how we could potentially expand CCBHCs across the state. Next slide, please. And so the next initiative again is the multi-systemic therapy or MST pilot. And so Medicaid, along with our partners such as our managed care organizations, Department for Community-Based Services, and Department for Juvenile Justice, began the multi-systemic, therapy pilot in 2021. And so this is a 5-year pilot. MST is an evidence-based and again intensive treatment process. And so it's focusing on the youth that does have behavioral health disorders, and really looking at those environmental systems. So their family, their school, their peer groups, and again, their communities, and how they contribute to and influence involvement or potential involvement in the juvenile justice system. And so MST again focuses on the family strengths, and it is to promote positive coping activities, working with the caregivers again. It could be reinforcing positive behaviors, reducing negative behaviors, and then, of course, increasing family accountability. But there are currently 4 providers that have been participating in the pilot, and this does run through July of 2026. Next slide, please. And so again, the initiatives that we highlighted today, they really are just to name a few. And as you can see, the behavioral health initiatives continue to grow in Medicaid, and really to address the needs of our beneficiaries. But to better understand the needs and the gaps in services, we are conducting a statewide behavioral health needs assessment. And so again, the needs assessment does provide an overview of current behavioral health landscape of services. It again is to identify areas of opportunity and growth. But not only again will it help to identify those needs and gaps, but it really again is to also help the state evaluate our access and capacity to services. But it also again will inform policy and program development of behavioral health services and future initiatives. Then again to really improve the quality of the services and outcomes for our beneficiaries and families. And then again, we certainly want to ensure that we are building equitable programs and services that we provide. But we are hopeful that the needs assessment and completed needs assessment would be available by the end of the year to share. So more to come on that. Next slide, please. So we'll pause. I know we're right at time. If there are any questions, but we will also continue to share specifically regarding the behavioral health team in Medicaid, but we do have a specific, we can try to get that dropped into the chat box, but we do have a specific behavioral health email that you can reach out if there's specific questions regarding any of the covered services or initiatives within Medicaid.
Thank you for that, Angela. I do want to apologize because we had a cyber attack on our chat, and we had to kind of shut it down for a little bit and make sure we were deleting and then blocking the person who was causing the chaos. So we do greatly appreciate you all with your patience and emphatically apologize for that. We unfortunately live in that world now that technology world now where that can happen. So I did have to turn off the chat feature for a while. I have turned it back on. We did have a couple of questions, and I was trying to respond to them as they popped up. There was a question about being able to do telephonic services for therapy and targeted case management. And so if that person would please email me directly and we'll get you an answer to that. I'm going to put my email address in the chat and feel free to send your question if we didn't get to it, to send your question to us, and we're happy to respond. Again, thank you again for taking time out of your day to be with us, and we hope to see you again next month. Oh, thank you. The other thing you could share with us, thank you, Beth, for popping that up, is if there's something you really want us to cover in a future meeting, please send that to us. We really are here. We're trying to do this for you, for the community. So if there is a particular topic you would like us to address, please send that to us as well. Thanks, and have a great rest of your day.